Dear friends, today I'm going to talk about treatment of congenital scoliosis. And I try to show some of my cases, how I treat, and I'm gonna make my decisions for congenital scoliosis. As most of you know, that the congenital scoliosis is a little bit different natural history and treatment techniques than adolescent idiopathic scoliosis. The congenital scoliosis is the lateral curvature of the spine, but it is due to vertebral anomalies. And these are usually easily seen on standard X-rays, but on rare occasions are discovered only on further radiodiagnostic evaluations such as MRI or CT. When we come up to the classification, we can classify as the defects of formation and defects of segmentation, and also there could be some cases with mixed nature. Defects of the formation, generally hemivertebra, wedge vertebra, sacral agenesis, or caudal regression syndrome. And here you will see that in very early age, intrauterine time, you may find out with ultrasonography that there is a hemivertebra in this patient. And this is another hemivertebra, which usually in the early period creating progressive deformity if they are very close to the base of the spine. And here are some other types of deformities, some of them hemivertebra, some of them hemi-segmented, some of them unsegmented, and some of them incarcerated, and some of them are incarcerated. And the other one is the defects of segmentation, usually seen as a unilateral unsegmented bar, posterior laminar synostosis, anterior unsegmented bar, and total defect of segmentations, which we call them as a block vertebra. Here you will see a thoracic unsegmented bar, and you can see on the X-rays how they behave. In a short period of time, within 1 year, it progressed from 53 degree to 82 degree. So as you can see, some of my examples that as a surgeon, we have to encounter with these deformities in a very early stage. About 25% of patients had no progression, and 25% progress very slowly. But the most majority, 50%, progress quite significantly with steady progression until puberty, and then very rapid progression during the time of rapid pubertal growth. So the severity of the congenital deformity depends on the type of the anomaly, usually hemivertebra, if uncarcerated, and if they are below L1, especially L5, L4, L3, hemivertebra progress very rapidly. And also the unsegmented bar also progresses very rapidly. If there's a combination of hemivertebra and the unsegmented bar, then this is the most significant progression have. One of the major problem of congenital scoliosis, they may come up with associated spinal anomalies. So at the first clinical visit, we have to examine the patient, look at the neurology, and also the posterior aspects of the vertebral body, the skin. And we have to do MRI, full spine MRI, to find out if there is any problems such as syringomyelia, tethered cord, or diastementomelia. So other congenital deformities also may associate with the congenital scoliosis, and most probably the genitourinary system, congenital heart disease, tracheoesophageal fistula, anal atresia, congenital elevation of the scapula, radial clap hand, and Golderhahn syndrome, most probable associated anomalies of this deformity. So at the beginning, after the first clinical examination, we have to send them to the pediatric doctors to find out if there is any of these anomalies. In this slide, you will see again our study that what percentage of associated anomalies can be seen in congenital deformities. So as I said before, the congenital scoliosis due to unsegmented bar with contralateral hemivertebra is the most progressive one. So after clinical examination and necessary consultations, we have to have the AP and lateral spinal X-rays, MRIs, if necessary, CT scan should be studied. When we come up to the treatment, what's the value of non-operative treatment? Most of the time, maybe more than 70, 75, 80%, it's a very limited value. We sometimes use the plaster jacket, underarm brace, Milwaukee brace, just to control the not always the primary curve, but the secondary flexible curves. Surgery, age of the patient, site and type of anomaly, and the size of the curvature is the determinant of surgical treatment time. So there are some prophylactic procedures and there are some salvage procedures. So within these techniques, we can use in situ fusion, hemiepiphysiodesis, posterior fusion and instrumentation, anterior posterior fusion and instrumentation, hemivertebra excision that can be done anterior posterior or only with posterior technique. Posterior fusion without instrumentation, sometimes it's satisfactory. The disadvantage we need to use the cast correction, and there could be a crankshaft phenomenon and increased risk of pseudoarthrosis. Nowadays, we don't use this technique. Most of the time, if we are going to do posterior fusion, we always use instrumentation. So the advantage of posterior fusion is instrumentation. We can achieve more correction, decrease rate of pseudoarthrosis, and there could be some disadvantages of using posterior fusion. So anterior and posterior fusion depends to the sagittal plane problems, increased flexibility of scoliosis, preventing crankshaft, and curvatures with significant potential progression. Anterior posterior convex with episiodesis, we usually do it before the age of 5, under the magnitude of 60 degrees and less than 6 segments with concave growth potential, no pathologic kyphosis or lordosis. Control for congenital scoliosis by combined anterior posterior convex fusion, children less than 3 years, 27%, more than 3 years, around 10%, the curvature less than 40 degree, around 34%, and above 40 degree, 5%. So we have to think all these findings and decide what kind of surgery we are going to choose for this type of deformities. So maybe nowadays we are using more hemivertebral excisions. It allows us to curve correction, shorter fusion, restore the trunk imbalance, and there is a possibility of having the neurovascular injury, but this is very, very rare. And here you will see that hemivertebral excision on the with only posterior approach on the right side. You will see that we remove all the vertebral remaining vertebral body with posterior instrumentation and correction of the deformity. Here are some case examples from my own series, and preoperatively 27 degree with unsegmented bar, mixed deformity, and it progresses up to 50 degree with only posterior fusion. So there is very little value of doing posterior fusion without instrumentation. Despite this kind of surgery, there is also progression. So again, you will see here that another hemivertebral excision with only posterior approach, and you will see with the X-rays that satisfactory outcome. And this is thoracic unsegmented bar, operated posterior instrumentation with fusion. This is a 5-year-old boy with L2 hemivertebra. Again, these are the cases that I'm showing to you right now, maybe 15 or 20 years history. This is another case with unsegmented bar, and we did posterior convex epiphysiodesis, and this is the postoperative view. This is another case, again with mixed deformity, and this is the result after 3 years old, 3 years postoperatively. This is again 2-level hemivertebra with congenital bar, and as you can see, first we did the hemivertebral resection, and then we start using growing rod technique because of to control the remaining curve. And this is 4-year-old boy with hemivertebra, and this is progression, and this is again 2-year-old boy operated with hemivertebral excision. Even though we perform the hemivertebral excision, you will see that now he is 7 years old, 5 years after the surgery, but the remaining curve should be addressed with growing rod technique. So this is just done hemivertebral excision, an acceptable remaining curve. He is 7 years old now, and we are still following his scoliosis. So in congenital scoliosis, most of the time we have to do more than one surgery, and we need to follow the patient until he or she reaches the puberty, and after the puberty, 2 more years to control the deformity. There is a very little value of non-operative treatment methods such as bracing, and most of the time we control the congenital part, but also the patient also has remaining structural curves. So we have to follow these patients with most of the time with the growing rod techniques until the end of puberty. So this is all I can tell you about the congenital deformity. At the beginning of the first visit, we need to talk with the family, that explain them. Sometimes 10 or 15 years, we have to follow the patient, and from time to time, we need to do some surgeries. And this is, I believe, that most of the most important part that we have to tell to the patient family at the beginning. Otherwise, they have some questions in their mind when we come up and ask them to have another surgery. So thank you very much, and hope to have a chance to see each other in the next time face to face. Thank you very much.